Thank you everyone for letting me join this. I'm going to speak on the applying the recommendations of these Lancet Commission in the context of Southeast Asia. And I've taken liberally from a lot of the people that I've stated here and subsequently at the back of this presentation. I thank Lindsay and Dr. Banavali for kindly giving the outline of things that provides the basis of a lot of my discussion. As Lindsay mentioned, the paper itself is actually a tome of information, a lot of statistical basis that will be very useful for people to use these in general for to get government and administrators to hop on the bandwagon. Southeast Asia is comprised of 10 countries in a grouping we call Association of Southeast Asian Nations, or ASEAN. ASEAN itself is rather large. It has a great disparity or disparate in population from very small countries like Brunei to very large countries like Indonesia, and very different gross domestic product per person in general, from low-income countries like Cambodia, Myanmar, and Laos in general, where low-income to very high-income countries like Brunei and Singapore. The survival rates for childhood cancer is also very variable based on these GDP light. As Lindsay actually have shown, this is the Southeast Asian map. In terms of the color, you can see that there is a range of red color from the lower income countries like Cambodia and Laos, the arc, and then after that to as high as Singapore, which cannot be seen, of course, and then Malaysia and Thailand. So the critical part, as Lindsay had mentioned, is that the return investment is really important. It's about $3 for every dollar invested, but this is not standard throughout in general. So for low-income countries like Laos, Cambodia, Myanmar, and some of the delegates that come from the lower income country, as Lindsay mentioned, you need the initial improvement will be very low. You need to be increasing investment to about more than 40% from current low level before you can get the improvement in terms of outcomes, as you will see. The reason is because you need a very strong healthcare system. One component alone is not enough. You have to reduce abandonment, and also there are other issues of high childhood mortality as well. But for the middle income country, which actually ASEAN and Southeast Asia has quite a bit, the promising countries like Vietnam, Philippines, and Indonesia, there will be a tremendous, almost exponential type of improvement with the investment in childhood cancer. And therefore, the systems becomes extremely critical. Malaysia and Thailand is a good example of how they have scaled up this in general to the levels where Singapore and in fact, Brunei is seeing at this current time. Again, this is the very nice diagram that has been showed multiple times. The commission itself, we debated very much on the levels of care. Like in India, as Dr. Banavali mentioned, you have top maximal care at like in the Tata Memorial Hospital, Tata Medical Center, and all like Christian Medical College, AIMS, and others will be functioning at high level 4, but actually there are very disparate places where access to care is much lower, and therefore there must be this feeding up of the care in general and referral up to the places where diagnosis is best managed, and then shared care downwards. One good example of what Prof. Hani Arifin has done in the Malaysia-Singapore ALL study group, for which she co-chairs, is that in University Malaya, patients are referred to University Malaya for diagnosis, induction chemotherapy, and even high-risk patients will be bone marrow transplant and others, but then they will then refer back to their shared care centers, like the various district hospitals, and using phone consults actually to be able to keep in touch with every 2 weeks, tracking full blood count, response and toxicity in general, and having a line coming back in general where they can call back to the main hospital or return back to University Malaya for treatment. Because of this capability, University Malaya can see far more patients than the National University of Singapore can in our hospital because of this capability. One important part, as Dr. Banavali has mentioned, is the universal healthcare coverage for childhood cancer. The reason of abandonment is that there's a lot of toxicity and financial risk for the family, and therefore the proposal is no out-of-pocket type of funding. But this is, I'm not sure whether that is really possible. For example, in Malaysia, the government funds most of the treatment in the government-based hospitals, and they provide outstanding care. For example, in Thailand, there is a 30 baht program, for example, where everybody pays 30 baht per, I think, per month into an insurance scheme, and therefore healthcare is then provided. Protocols are based on these type of funding. For example, Vietnam again also have a national insurance, and with this national insurance, less than 6-year-old children receive free care. And for older patients, co-payment 20%, for example, will be needed. For Singapore, Singapore prides itself very much in a co-payment system. That means everyone is responsible for their health, and therefore there is an important co-payment of 20 to 40% in general. There is a national insurance that pay for large devastating illness like cancers, cardiovascular disease, but they don't pay very much for small diseases like appendectomy, for example. In order to encourage funding in areas that the government doesn't provide, like what Dr. Banavali have mentioned for India, Singapore does it by tax exemption. That means for every dollar you donate, you can have a $3 tax exempt back in terms of charitable support to various programs like childhood cancer and various charity programs. So the other important part, it's itself really for a pediatric oncologist, for many of us, actually like my boss in the picture here, when he first started treating children with cancer, you feel very alone. You are like fighting the system, handling difficult patients, challenging issues, infections, complication, wrong diagnosis, and all that. So you oftentimes feel very much alone. And because of that, the Viva Foundation in Singapore, together with St. Jude Global, has focused really on reaching out to people, providing education, mentorship, and a network so that you are actually not alone in the fight of cancer in general. So we have really recently formed under the St. Jude Global umbrella, the ASEAN Childhood Cancer Alliance, for which various programs will then come together. Viva Foundation have organized up to now probably 14 annual forums where pediatric oncologists join in Asia, very much like PSYOP Asia, to learn from the best people and to network. Critically, in terms of training, I will share later about the UMP program in Vietnam led by Michelle Hermiston, which is a very powerful fellowship training method based on the best principles of training. Importantly, access to information is very important. PODC guides and tier guides and like Cure for Kids and free journal access for poor countries itself is very important. And I think these are important in general. Singapore just emerged as a first high-income country, probably over the last 20 or 30 years. A critical thing that we have learned really is that the first Prime Minister, Mr. Lee Kuan Yew, says you need to learn and speak in English because that's the only way that you can learn from the best. So I would really urge everybody to speak as well as Dr. Banavali in English. I think that really is very critical. In order to, because the private sector pay 3 times more, government has started paying government doctors like myself, leveling up the pay, not as good as private sector, but it makes that people like us could survive on the pay that we have, which unfortunately is not the problem, a major issue in countries like Indonesia, Vietnam, where the amount of pay that we receive is too little. Because there is a lot of leakage of doctors and nurses in the private sector, the government ramped up training for doctors in general to cater for aging nation in Singapore, as well as children in general. And various tracks are already set up for nursing in particular. They have actually proper nursing career to be nurse clinicians, advanced practice nurses in general. That's very helpful. I would like to take the example of Vietnam, which is really, in my opinion, one of the best model of care in general. There are some problems that they faced. Pediatricians are not licensed to prescribe chemotherapy. So pediatricians, pediatric oncologists treating children with cancer have to get medical oncologists and adult hematologists to sign their chemotherapy form, which is really quite perverse. There are various treatment protocols throughout the country. Pediatricians will use the COG, CCG type. The adults will use the FREL protocol, for example, and therefore there's very disparate in different types of treatment and very disjointed. And there's actually no data available. So the Vietnam government now have sanctioned 7 national childhood cancer centers throughout the whole of Vietnam, and including of some blood centers and cancer hospital to treat children with cancer. And that's a good start, I think, to focus on this. As I mentioned, the University of Medicine and Pharmacy in Hanoi worked together with Dr. Michelle Hamiston to develop a fellowship pediatric oncology program funded by Terry Fox Foundation in Vietnam, led by this wonderful gentleman known as Anthony, and various people, Chad, Anu, Sally Bear, myself, and others have contributed to teaching groups of these fellows, and they are really using curriculum, training them as much as they can. In fact, I think they trained these fellows better than us in Singapore. Leadership is critical. An example is really the Philippine doctors like Dr. Trisha on the first picture and Dr. May Dolando hiding behind the kids. We trained May, and she has gone back to set up the Southern Philippines Medical Center with St. Jude Global Program, and this center is now larger than us in the National University of Singapore. They have also come up with the National Childhood Cancer Control Act, and the Field Health Program have Z benefits that fund childhood cancer treatment, their licensing program, outreach program, and it helps very much when May has a phone call with the president of Philippines in general. However, COVID itself has dealt a very severe blow to Asia and Southeast Asia, especially like Philippines, Indonesia, where we actually lost doctors, nurses, and there are lots of talents also to other countries because Filipinos speak English and they are really an asset. As what Dr. Benavli mentioned, is that there is no childhood cancer registry in most of these countries, and that is a big problem. If we have no data, how are we going to improve? India has the special number that everybody has, but if we follow the footsteps of United States and sadly even Singapore, where there's a personal protection of data, we can no longer collect data in general. And if we collect data, we need to get consent and others. So this is really very a step backwards for most of these countries who really have problems collecting good data. And St. Jude registry have created very nice, safe standard fields where they can be actually input in. But countries like Vietnam, for example, do not allow such uploading data into a server outside of Vietnam. So we shoot ourselves in the leg, and therefore we reload the gun. And I feel that we should speak some way as a voice to avoid these problems that the American policies and European policies have caused problems for these countries that could not afford it. The problem with childhood cancer is that our medications are cheap, they are generic, and therefore nobody wants to sell them to poor countries, especially if there are a lot of registrations that are needed in general. Mercaptopurine, for example, is always unavailable in Indonesia. L-asparagines, Vietnam shortage in general is a problem. There are actually a lack of diagnostic standards, and really there's very little studies done in Asia about treatment. For example, for probably more than 20, 30 years, my boss, Professor Kwa, believed that Asians are very sensitive to mercaptopurine. It's only back in 2014 and 2015 when the NUT-15 variant has been actually discovered and worked out, and therefore these are very important. As I mentioned, there are various issues, guidelines must be practical, must be tiered, must be simplified, because the doctors are very busy and therefore don't have time to address a lot of these issues like varicella, tuberculosis, fungal infection, and others. So in summary, really, I would like to say that I've taken parts of the Lancet Oncology Commission recommendations and use these examples how Southeast Asia and ASEAN have actually learned how to apply some of these and how we can continue to apply some of these in the future. Thank you very much, and thanks very much for the invitation.